But it's a very common problem, and so we'll just take a little bit of time here to go through it. Most of this in children is somewhat straightforward. I say that a little hesitatingly because it can be complex, but we all see back pain, and if you like to do, say, spinal deformity work, which most of us do, you're going to see back pain. You can't do the fun stuff without some of the mess. So this is just hopefully a general sense of some quick diagnoses and some exam tips to help sort out back pain in kids. I have no disclosures for this talk. One thing I will say up front is that this talk will not deal with any type of trauma. We don't do the spine trauma at COSAIR. The Leatherman spine people handle all of the spine trauma, so this talk won't address any kind of, say, back necessarily injuries or fractures, anything like that. It'll be more just generalized back pain. So the objectives: to improve exam skills, understand common causes, and concerning signs or symptoms for back pain. So it's more common than you may think. In primary care, the relative incidence of, say, adults presenting to primary care with back pain is up to 50%, and so in kids and adolescents, it's fairly close to that. It's definitely common. Adolescent back pain has been studied a lot of ways and found to have about a third of teenagers present to their primary care doctor or a specialist with back pain throughout their growth. And the causes, again, are multifactorial. So the good thing is childhood back pain is usually not something structural. It's actually much less common to be something structural as opposed to, say, adult back pain. Kids rarely get disc herniations, spinal stenosis, nerve root impingement, arthritis, those kinds of things. Yes, they can, but it's much less common than in adults. So common causes, the most common cause in, say, an adolescent or a teenager would be a muscle strain or some other type of muscular problem. Pain can be due to very rapid growth. These kids in their kind of prepubertal growth spurt are shooting up like crazy. That airplane is really taking off, going vertical, and their muscles, just like some of the overuse syndromes we talked about this morning, their hamstrings, their core, their back muscles are feeling the effects of this rapid growth as well. So that alone can be a cause of back pain. Tight hamstrings, we mentioned, core and trunk weakness is usually a common problem with most of us here. So Amanda's gone, so she didn't have a problem with weak core. But structural causes. There are some structural causes in kids. Spondylolysis, spondylolisthesis. I'll talk a little bit about those as we go along, but you can have little defects or stress fractures, say, in certain parts of the spine where they can even cause a deformity or a slip. And then some other less common causes, but I'll tell you more common than I first realized when I came out 8-9 years ago to start a real job, say, after training, and spinal cord problems, tethered cord, syrinx, diacetylemyelia, GI problems, chronic constipation. Dr. Jacks likes talking about that. We all have to talk about that because, again, I didn't realize how much that plays a role in kid back pain, especially in, say, the neuromuscular population. Infection can definitely cause back pain. We'll talk a little bit about discitis, tumor, both benign type of bone lesions and malignant. So like anything, the history, we ask about the mechanism. You know, you can see all this up on the slide here: duration, quality, what makes it worse, what makes it better, those types of things. I think most of us, if not all of us in this room, are capable of doing that. Associated symptoms, though, we always ask about bladder or bowel symptoms. Constipation, urgency, they're 10 years old and they're still having some bedwetting problems, or maybe it's a newer problem like that. And if you don't ask, and sometimes it takes a few questions to get them to open up to talk about that, because it's not something that everybody wants to admit to. Radicular symptoms, shooting pain in the legs or arms, numbness, tingling, those kinds of things. Even younger kids know kind of what numbness and tingling feels like if you kind of ask them about it, or in a way that they can understand. Weakness, thank goodness that's really uncommon in childhood back pain, but obviously if you see weakness, that'd be a concern. So here's some red flag symptoms. These are things that should maybe think about getting the safety car out here a little bit. Pain that stops activities. Most of these things, much like the knee or the foot, these overuse things, well, does it stop your activity? No. I still play basketball. I still play baseball. I do that. It doesn't typically stop their activities. But if they say, well, I used to be a gymnast and I had to stop because my back hurt so much, that's a concern. Doesn't mean something is necessarily seriously wrong, but it's something to raise your flag a little bit. Pain requiring medication above NSAIDs. If they are taking Motrin or Tylenol, or they're asking for narcotics, or somebody's given them Valium, or they've taken mom's Robaxin or something like that, that's a little concerning. And then night pain. Not just necessarily, well, I have trouble getting to sleep because my back hurts. We think of night pain as pain that awakens you from sleep. You wake up because, oh, my back really hurts. So that's, to me, is night pain. And so those are what I kind of call red flag symptoms. And so these are not that typical. Lots of kids have back pain with activity and things, but it doesn't typically stop their activities. And so this may be an indicator for a more serious problem. So their exam, some of this has been touched on already today. The standing position is important. The Adams forward bend test, again, obviously looking for deformity, sensory exam, reflexes, those kinds of things. If you have a giraffe hammer, that is even more helpful. Standing position. So we're going to evaluate the shoulders and pelvis. Back pain, spine deformity, and limb length difference can be all tied together. Oftentimes, anytime we do a scoliosis check, we always look at their limb lengths and the level of their pelvis. If their pelvis is unlevel because they have limb length inequality, that may be a reason that they are referred for scoliosis or back pain. So we're going to look for that. And you can see from that diagram here that it's fairly easy to assess in the standing position. Their motor sensory exam, here again are their dermatomes, and so basically I can do a pretty quick exam of their motor function and strength in the office if I have them walk on their tiptoes, their heels, hop up and down on each foot, and squat. Essentially that tells me that everything from their gastroc up to their hip flexors is working. Okay, and like I said, since a big motor deficit, things like that, is unlikely, as long as they can do all those things pretty easily, I'm comfortable that their motor function in their legs is intact. So their skin, this kind of shows up. So this would be an example maybe of a sacral dimple. And so we're going to kind of pull their shorts down just a little bit, and I tell them why I'm doing it, because it seems kind of weird, but I explain this is what I'm looking for. I'm looking for dimples, hairy patches, any type of, we'll call birthmarks, cafe au lait spots, things like that, that can give an indication as to maybe a reason for back pain. And we'll get into what that means here in a little bit. Just because they have a sacral dimple doesn't mean that it's going to make their back hurt. But, the forward bend test, again, you're looking for rotation. Here in this diagram here, you can see how the ribs are elevated on the right side compared to the left. And so that would be an indication likely of either spinal deformity, potentially shoulder blade asymmetry, things like that. Does it elicit pain? Do they have pain when they bend forward? Or, for example, we document how far can they bend forward. They can bend forward till their fingertips touch the floor, or they can bend forward till their fingertips get just past their knees. That could signify tightness, for example. Palpation, midline tenderness, paraspinal tenderness. Most kids or adolescents with back pain will have some degree of lumbar muscle spasm. And so you can sometimes feel that on exam, or they'll say, oh yeah, that kind of hurts over my muscles. It's less common to have, say, midline point tenderness. Step-offs, if they have a significant slip, spondylolisthesis, you could maybe feel where there's actually a dip or maybe a gap or something when you palpate their spine. And so imaging. So this is just recently off the internet here. The American Academy of Family Practice suggests to not do imaging for low back pain unless it's been present for more than 6 weeks or within the first 6 weeks. So that's because it's very rarely something, and this you can extrapolate this into kids too, it's very rarely something you would actually see on an x-ray. And so typically, from a primary care standpoint, x-rays aren't really even indicated. We will typically do them because we are a specialist or a referral, that kind of thing. And if they walk out of the orthopedic office without x-rays, I think a lot of them may feel a little shortchanged. So we typically will do them to look for a few of these things that may present in kids. Obviously, again, if you have a concern for spinal deformity, scoliosis, of course x-rays would be appropriate at that time. So this is not meant to be a comprehensive list of causes of back pain in kids or adolescents, but I think it hits on the main things that we want to be aware of. Again, we'll call musculoskeletal, muscle strain, weakness, growth, that general family. That would be the most common thing in kids to cause back pain. Neurologic or spinal cord issues, tethered cord, syrinx, we'll go into a few of these, and we talked about some of that. So treatments. since most of the problems are, say, musculoskeletal in nature, not necessarily structural, time and non-operative therapies are almost always successful, okay? They may need time off of their sports, as we've talked about many times, and you kind of have that reaction. And counseling and education to say, look, we can't fix this maybe today, but here are some ways we can try and make your back pain better, and such as, okay? Lots of, we'll say, home treatments we'll start with. We have a back pain sheet that we can print out that just kind of goes over some general things of back pain, where if they're kind of like, okay, good, I just wanted to make sure nothing was seriously wrong. What can I do at home to treat my pain? Because it's really okay. I just wanted to see if I could make it better. So ice, heat, topical treatments. Again, this is not an advertisement, but I do like Shaq. So anti-inflammatories, stretching. Yoga is actually very good. You don't have to do yoga, but that's not an uncommon question, and I think that's an excellent way to strengthen and stretch. So activity modifications may be needed. So those are some general guidelines you can follow, even if you're not sure right away if there's a true structural problem that really aren't going to lead to any harm to the kid. Some advanced treatments. Raymond can work on you, okay? So you don't have to have white pants, but it does help. Physical therapy is I send almost every child, unless they have a true structural problem that's obvious right away, to physical therapy. And I think that is absolutely something that is helpful to these kids. And even when we talk about a few of these other structural problems, therapy still is oftentimes a big part of their treatment. And so they'll work on core strengthening, hamstring stretching, modalities, those kinds of things. And I know there's some therapists in the room, you're much more well-versed in treating this and talking about this than I am, but therapy is a very important part of this. It often takes time, okay? Again, my standard line is I can't fix this today, but it may take some time. So if they've had back pain for a year or two, it is not going to go away with 2 weeks of physical therapy, okay? I make them do at least 6 to 8 weeks of therapy because that's a fair test, okay? And I tell them, those first week or two, that's not going to make you feel that much better. You might feel worse, okay? If I go out and run 5 miles today and tomorrow, I'm not going to feel very good. But a month from now, I might feel okay, all right? So it's important to get them to understand that this is going to take some time. Okay, we'll talk about a few kind of separate things here. Tethered cord. Most of you, if not all of you, know what a tethered cord is, and maybe have seen kids with tethered cord, that kind of thing. So just as a review, the spinal cord starts lower in your spinal column when you're a very young child, and as you grow, that spinal cord grows with you, and the bottom of the actual cord migrates up in your spinal column. And so if it's tethered or stuck, say, by a fibrous band of tissue, that can lead to stretching of the spinal cord as you grow, and nerves don't really like to be stretched. They don't like to be retracted. They don't like to be banged on. They don't like to be stretched at all. So that can lead to some symptoms. So here's just a little picture of kind of where a normal spinal cord, which would end at about L1 or so, and the nerve roots then coming down there. So a tethered cord is where you maybe have some fatty tissue or some fibrous tissue that's tethering it, and the bottom of the cord is actually lower than it's supposed to be. And as they grow, they can get more and more symptoms. So back pain, leg pain, this is where constipation comes in. Lots of kids get constipated. Not all of them have tethered cords, but just something to be aware of. Bladder control, tightness. If they can only bend forward till they can barely touch their knees, that's really tight, okay? And so then you see one of our friends here, Dr. Moriarty or Dr. Gump or Dr. Munchnick, and they're the ones, a neurosurgeon is who takes care of that, okay? And so that's what we'll do. And so an MRI is usually the test of choice, or is the test of choice, to see if the spinal cord is tethered. And on occasion, and I learned this from Dr. Jacks when I was younger, even if the MRI is normal, but they have, say, most or all of these symptoms, I may send them to neurosurgery to say, have them tell you that it's not tethered, because we have excellent radiologists, and they're fantastic, but even then, the MRI can be normal, and the neurosurgeon may say, boy, you have so many symptoms, let's take a look anyway. Not common, but on occasion. Spondylolysis. It's a defect in the posterior spine called the pars intra-articularis. It's just this little area here between the joint and the joint, okay? It's in the back of the spine, and this can be a multitude of causes. Can be traumatic, can be overuse, so more of a stress fracture. Typically, people who do hyperextension activities, linemen in football, divers, gymnasts, those people who bend backward, that girl on America's Got Talent who could fold herself up, you know. Those are the kind of athletes that are going to get this problem because there's just chronic pinching of this area back here with the bone. So, and that can lead to low back pain. Here's an example of a CT scan showing that defect there, where if you look at the level above here, that's completely normal there. There's the joint or the facet joint, and there's the small crack or defect there, okay? So, and if this bone slips forward, say, on this bone, that's a spondylolisthesis, okay? Physical therapy, and again, in time, are the mainstay of treatment. This is rarely an operative problem, especially in adolescents, okay? So even if they have this documented on MRI or CT scan, I'm still going to send them to therapy. One of my mentors when I was training said he would never even offer surgery on somebody if they couldn't put their fingers on the floor, because that just showed that they were still too tight to really know if that was causing their pain. Discitis, really rare. I've seen it a couple times here in about 8 years, but you don't want to miss it. So younger kids, typically kids who are 6 or 7 are not going to have muscle strains or back pain due to that, but they could have an infection. So you can have an osteomyelitis of the spine here, and that can actually migrate into the disc space. And so that can cause acute pain pretty quickly. Here's an MRI example of a discitis and associated osteomyelitis of the spine. You see narrowing of the disc space, and this is pretty much more acute, more rapid symptoms. Typically, you recognize this more in the hospital setting because a child comes in with a few days of back pain that's gone from mild to fairly severe over a short period of time. And the treatment typically would be antibiotics and occasionally operative debridement. So a few things on scoliosis. This is not thought to be a direct cause of back pain. Okay, we have kids fairly frequently who come in with curves like this or bigger that we think surgery would be an option for, and they have no pain at all. Okay, we have plenty of kids with straight spines that have a fair amount of back pain. Doesn't mean that you won't have back pain if you have scoliosis, but in general, it's not going to cause significant back pain. Looking at studies, there may be an equivalent amount of back pain in kids with scoliosis versus non-scoliosis. There may be a slightly increased incidence of that, but again, it's not something where just because you have scoliosis does not mean you'll have intractable back pain for the rest of your life. So what about backpacks? We get this question asked a lot, okay? Again, there's no evidence to suggest or show that wearing a backpack that's too heavy or with one strap or things will cause a structural spinal deformity, okay? That being said, backpacks nowadays are heavy. Kids are carrying a lot of books, computers, those kinds of things. So a general recommendation, and even the people who make these recommendations admit it's not real scientific, 15 to 20% of your body weight in a backpack is thought to be about appropriate in general. So altogether, the most common cause of back pain in adolescents is what I'll call musculoskeletal. Weak core muscles, muscle strain, growth, some combination of that. Advanced imaging is really not routinely needed, apart from an X-ray in general. Physical therapy can almost always be tried first unless you have some imaging findings or something suggesting otherwise. So remember tethered cord or other spinal cord problems, say in younger kids especially, with associated symptoms. And then again, remember red flag symptoms of night pain that awakens them, pain that stops activity, or pain with that needs frequent medications. So, all right, thank you very much. Okay. So, and then our last talk of the day here is going to be Dr. Sarah Stewart.